I know, as you all know, that clean hand always counts. So hands are the number one way of germs can be by way germs are transmitted. The lack of hand hygiene contributes to the spread of resistant microorganisms, and it supports the patient safety. So make cleaning in your habit. That is, clean in and clean out. Clean when entering the resident room or care space, and clean upon exiting the resident room. So most of the time when provider enters the room, they make contact with the environment or the patient. So study shows 92% of the time the environment will be touched, and 57% of the time the patient will be touched. So it consistent with the leading hand hygiene practices. So now coming back to that, we all know WHO six-step process is effective, but recent data are inconclusive. Think that in a systemic review of 9 studies carried out by WHO and published in American Journal of Infection Control, investigators examined the effectiveness of WHO six-step hand hygiene technique and compared it with other, including CDC three-step technique and a modified or adapted three-step and six-step technique. The CDC method involves applying an alcohol-based hand rub covering all the hand surfaces and rubbing them together until it's dry. So the data in 9 studies were varied. Some of them found that WHO six-step techniques were more effective. Others found there is no difference between the CDC and WHO. This review identified the need to include a thorough description of hand hygiene techniques, sampling strategy, population, or sample in each study when reporting the finding of hand hygiene research. Checklist for reporting hand hygiene studies is warranted to help improve the evidence base. This review also showed that the studies differed in terms of study design, data collection, hand hygiene techniques being compared, hand hygiene products being used, their volume, their application time, and these differences could have contributed to inconsistency in the findings. These are the confounding factors. The WHO six-step methods of hand hygiene is still the gold standard. However, most healthcare personnel do not take or have the time to do it correctly. So, while searching for the literature, I found this very interesting article in clinical published in CID in 2019 that they did a cluster randomized trial between simplifying the WHO protocol with three-step versus six-step for performance of the hand hygiene. So, in an experimental setting, a simplified three-step hand hygiene technique for applying alcohol-based hand rub was non-inferior in terms of reduction of bacterial counts as compared to conventional WHO six-step technique. So in clinical setting, the simpler hand hygiene technique consisting of 3 steps resulted in higher compliance with both hand hygiene indication as well as technique as compared to the 6-step. As the results of the microbiological analysis exclude inferiority, the conventional 6-step could be safely replaced by simpler hand hygiene technique. That is their recommendation by this cluster randomized trial. So coming to the composition of hand rubs, because Dr. Anup was very much eager that whether we should use chlorhexidine to their formulation in the hand rubs or not. If you see, there are standard formulation WHO1, WHO2, and US formulation. So when WHO1 formula consists of ethanol, glycerol, hydrogen peroxide, and water, WHO formulation 2 consists of isopropanol, glycerol, hydrogen peroxide, and water. Similarly, the US formula also have the similar formulation as WHO2, but in the leading brand like Microshield, it contains, along with ethanol, 0.5% chlorhexidine weight by volume. And another thing, Purell, which is another an US-based company, which is only a ethanol-based composition. Now, actually, what do you need CHG or not? Surgical hand preparation is an essential part of modern surgery. Both alcohol-based and antiseptic detergent-based hand preparation are recommended practices with a trend towards use of alcohol-based hand rubs. However, discussion has arisen whether chlorhexidine is a required ingredient in highly efficacious alcohol-based formulation in view of providing sustained microbiological efficiency. Let's see what the evidence says. So this is a paper by Henning et al. Published in Antimicrobial Resistance and Infection Control in 2017 that clearly says chlorhexidine is not an essential component in alcohol-based surgical hand preparation. A comparative study of 2 hand rubs based on a modified EN 12791 test protocol. Now they choose one alcohol-only product and another product which contains ethanol and your chlorhexidine. So they both are compared with each other using a modified test protocol based on European standard EN 12791 with 25 healthy volunteers. Now, the alcohol-only formulation, which is a product A, was applied for only 90 seconds. The chlorhexidine-based formulation, which is product B, which applied for 180 seconds. The microbial load reduction factors were determined and statistically compared immediately after application and 6 hours under the surgical gloves. So if you see the values of product A, which is only the alcohol-based product, is significantly greater than those for the product B at both measured time points, that is 0 and 6 hours. So an optimized alcohol-only formulation tested according to a modified EN 12791 protocol with 25 healthy volunteers outperformed a chlorhexidine alcohol formulation both immediately after application and also 6 hours after under the surgical glove. Thus, optimized alcohol-only formulation do not require chlorhexidine to achieve potent, immediate, and sustained efficacy. In conclusion, chlorhexidine is not an essential component for alcohol-based surgical hand preparation. So, among different hand hygiene agents, alcohol-based hand rubs are generally most well tolerated on skin, and true alcohol allergies have not been documented beyond reasonable doubt. And irritant contact dermatitis from alcohol is very rare when hand rubs were well formulated with emollients. On the other hand, chlorhexidine is known allergen and a frequent cause of irritant contact dermatitis among healthcare personnel, and it has also been subject to recent US FDA warning about rare but serious anaphylactic reaction. Thus, there is a clear potential for tolerability advantage from alcohol-only hand rubs for surgical hand preparation, especially if their antimicrobial performance characteristics are equal to or even better than those with CHG containing. Now, as we know, Candida auris is very difficult to get away with germs. So this is from a sheer publication of hand hygiene. So the study examining the dermicidal activity of hand sanitizing preparation against Candida auris demonstrated that 70% ethanol-based hand sanitizer resulted in 4-log reduction in contrary to the CHG-based reduction, which is less than 2 logs. So randomized control trial examined the effectiveness of 3 hand hygiene protocols comparing alcohol-based hand solution application to all hand surfaces, alcohol-based hand solution application using WHO recommended structured hand rub and chlorhexidine hand wash, and alcohol-based solutions was as effective as a chlorhexidine hand wash in reducing bacteria on hands, and alcohol-based hand solution application was the most time-efficient way of hand hygiene. The residual effectiveness has been demonstrated with formulation that combine with alcohol with either 2 to 5% CHG. Such formulation may be beneficial mainly if used in high-risk areas like ICUs and transplant units. So now again is a very controversial topic, the use of gloves and use of sanitizer over it. So use of non-sterile gloves is intrinsically linked to hand hygiene, not only providing benefits like reduced hand contamination during care, but also introducing risks such as increased hand contamination during duffing and increased contamination of patient care environment. So studies evaluating the transfer of environmental contaminants to gloves and bare hands have reported a reduction in hand contamination when gloves are worn. So hand contamination increases when gloves are fit poorly. That is when it is too large. As anticipated, failure to wear gloves was independently associated with hand contamination following care with patient with C. difficile infection. So, and a randomized clinical trials studying the impact of non-sterile gloves use after hand hygiene versus hand hygiene alone for all care, no significant difference was detected in late onset invasive infection or necrotizing enterocolitis in neonates cared for by HCP in these two groups. But there is significant few gram-positive bloodstream infection and centrally associated bloodstream infection occurred among neonates whose care providers done gloves after hand hygiene. Those findings suggest that hand hygiene plus donning non-sterile gloves before patient and vascular device contact may lessen the risk of infection among units that care for preterm neonates. So there are numerous barriers for hand hygiene prior to use of non-sterile gloves has been reported. So in a quality study, healthcare professional reported that donning gloves on wet hand was unpleasant and donning gloves without hand hygiene immediately prior saved time. So this is a very interesting thing that in an ICU, when hand hygiene prior to donning gloves was compared with direct gloving, there is no hand hygiene prior to donning non-sterile gloves. There is a significant difference in average coliforming. There is no significant difference in average CFU on the surface of the gloves, but it took 31.5 extra second to perform hand hygiene before donning gloves, which equates 20 minutes of extra time for the average ICU nurse caring for a patient in a contact isolation during a 12-hour shift. That is quite a time. So neither CDC nor WHO consider donning non-sterile gloves to be an indication for hand hygiene, but it is frequently associated with moment 1 of WHO of my 5 moments and the CDC indication for hand hygiene prior to patient contact. Infection preventionists and hospital epidemiologists should evaluate the potential impact to patient and HCP safety associated with direct gloving to determine whether it may be considered compliant according to the facility policy. Inappropriate glove use during task when there is no risk of exposure to infectious matter or failure to change gloves at appropriate moments during care has been associated with environmental contamination. So, double gloving has been proposed to further reduce hand contamination. But in a study examining double gloving using a non-enveloped viral surrogate for Ebola, inner gloves of 8 out of 15 participants were contaminated. Even one participant who did not have inner glove contamination had hand contamination. So these researchers concluded that random contamination events can occur even when double gloving is used, and they emphasize the importance of hand hygiene after doffing. So incorporation of disinfection of gloves with alcohol-based solution during task saturated clinical care has also been investigated to reduce hand contamination associated with glove use. Now, these studies were performed independent of glove manufacturer. In one study, disinfection of glove during care episode led to increased adherence of hand hygiene. Exposure to alcohol-based hand solution did not impact tensile strength of nitrile gloves. However, the risk of perforation increased when gloves were worn continuously for more than 15 minutes following wound dressing changes and following patient or resident bathing activities. So, disinfection of gloves prior to doffing is included in CDC guidance on PPE using in response to certain high consequence pathogens as in COVID-19. So, HCP should be instructed in appropriate use of gloves, facility expectation related to hand hygiene prior to donning gloves, when to change gloves during care, and methods of doffing reduce hand contamination. Ongoing observation of glove use, donning, and doffing is indicated, and with immediate performance of hand hygiene following doffing should be conducted when monitoring adherence to the hand hygiene. So, facts: gloves reduce hand contamination as much as 70 to 80%, but gloves need to be changed between residents and hands should be cleaned immediately after glove use. Now, coming to the effective volume. So, what is the effective volume and what is the dose you need? So, the volume of hand sanitizer or antimicrobial hand wash formulation may be considered a dose, and the dose must be sufficient to cover all surfaces of your hand. So, touch-free dispenser provide a mean dose ranging from 0.6 ml to 1.3 ml with a mean drying time of 12 to 22 seconds. For person with large hands, a dose of 4 to 6 ml may be needed to achieve more than 2 log reduction in bacteria on the hand. To obtain antisepsis, the volume of an alcohol-based solution should be customized according to the size of the individual hand. The volume may be communicated as a pumpful of the hand sanitizer and may require more than a single activation. So, now how long we should do hand hygiene? Techniques for hand washing and hand sanitizing should focus on coverage of all hand surfaces with appropriate length of time. The literature review did not identify the studies examining the duration of hand washing, minimum 15 seconds of scrubbing for routine hand washing, as previously recommended by CDC. Studies has reported no differences in bacterial load when comparing hand rub duration 15 and 30 seconds, but adherence increased to 27% with shorter rubs. That means 15 seconds rub. So when the techniques was included into the observation and adherence to the indication for the hand hygiene, only 7% of healthcare personnel attained full coverage of all hand surfaces. The thumb and the fingertips were most frequently missed areas for hands. Attainment of full hand surface coverage while rubbing for 15 seconds or longer should be included in HCP evaluation of hand hygiene techniques. Now, coming back to this very nice article published in Antimicrobial Resistance and Infection Control. It is a systemic review of factors influencing the effectiveness of alcohol-based hand rubbing in healthcare. So there is 20 studies were included in this review. Categories include ABHR volume, application time, rubbing friction, and there is insufficient evidence to change WHO recommendation of pump full of ABHR in a cupped hand applied for 20 to 30 seconds or manufacturer recommendation volume for about 20 seconds as per CDC. Future hand hygiene research should standardize volume, application time, and consider hand size. So again, surgical hand wash, how long is too long? So Hingst and colleague compared the hand bacterial counts after 3 minutes and 5 minutes scrubs with seven different formulation. Result shows that 3 times scrub could be as effective as 5 minute scrub depending on the formula of scrub agent. Immediate and post-operative hand bacterial counts after 5 minutes and 10 minutes of scrubs with 4% fluorescein gluconate were compared with O'Farrell and colleagues before total hypertroplasty. The 10-minute scrub reduced the immediate colony count for more than 5-minute scrub. However, the difference between post-scrub and post-operative mean CFU count is higher for 10-minute scrub than the 5-minute scrub. In longer, that is more than 90 minutes procedure is there. So the study recommends 5-minute scrub before total hip arthroplasty. So evidence-based hand hygiene, liquid or gel, hand rub, does it matter? There is another wonderful publication by Vonaitis et al. In antimicrobial resistance and infection control. The 1.5 ml ABHR commonly applied in healthcare setting is insufficient in either formulation as non-covered area exceeded significantly more than 5% in total hand surface area. 3 ml on the contrary resulted in almost complete coverage. Uncovered area remains below 1.5%. Now, the study shows that 1.5 ml volume was insufficient and the large part of surface was uncovered. When 3 ml hand rubs was applied, the drying times were 40 to 42 seconds in gel and liquid respectively. So it looks like we cannot find a volume that fits for everyone. So as Dr. Anup is also a very good advocate of personalized medicine, so there is personalized hand rubs volume because the hand size based on AVHR volume may be the solution of to find the optimal balance between the maximize coverage and minimize spillage and drying time. So again, there are the feedback measurement by which hand hygiene methods are measured. That is by direct overt observation, by direct forward observation, automated hand hygiene monitoring system, remote video observation, patient as an observer, and indirect methods. Indirect method is the consumption of the hand rubs. So there is 2 papers published in Antimicrobial Resistance and Infection Control in 2020 and a 10 years of hand hygiene excellence, a summary of outcome and a comparison of indicators from a award-winning hospital worldwide. A retrospective analysis was performed on dataset of HAGA forms, including the data of hand hygiene compliance, alcohol-based hand rub consumption, and hand hygiene self-assessment framework scores. The descriptive statistics were reported for such variables. The correlation between variables was inspected through Kendall test, while possible non-linear relationship between hand hygiene compliance, ABHR consumption, and HTSF scores were sought through locally estimated scatter plots, smoothing, or logistic regression model. So it showed ABHR consumption above 20.
Maybe just wrap up within 2 minutes.
Yeah, sure. So ABHA consumption about 20 milliliters per day was widely reported, and we observed a positive correlation between compliance rate and ABHA consumption. And obviously, HSF score were more likely to find in high ABHA consumption groups. So again, same type of study as the effect of 5-year hand hygiene initiative based on WHO multimodal hand hygiene improvement strategy. So they all by Suzuki et al. So they also shows an annual ABHA consumption was strongly correlated with annual HHSF score. So the indirect methods of measuring adherence to hand hygiene include volume usage or event counters. Adherence to hand hygiene opportunities based on volume usage is often not attributed to specific department or units or facility. When attempts were made to correlate usage with the observational data, researchers noted high compliance by direct observation with no correlation to volume usage. This finding led them to suspect biased observation due to the Hawthorne effect. Using an environmental assessment to identify points of care and anticipated number of hand hygiene opportunities, indirect methods were used by one facility to determine that the facility would need 2 lakh liters of hand sanitizer annually to attain high rates of hand hygiene. This finding may not be helpful in measurement of adherence, but may provide insight for emergency planning. So We need to speak up for patient safety. Patient safety is a team effort. Be empowered to speak up and remind their colleagues if they forget to perform hand hygiene. Lead by example. The key takeaway to promote health, debunking hand hygiene myths is essential. Proper hand washing techniques should be adopted as they are critical to preventive disease transmission. Thank you.